Good afternoon, everyone, and thank you for joining us for a special session of Madison Grand Rounds today, the Dream Speaker Series. This series represents a unique initiative that was designed to empower residents and fellows by giving them the opportunity to nominate distinguished speakers who inspire them and make significant contributions to our academic and clinical community. By selecting speakers through the perspective of our trainees, we foster a spirit of collaboration and innovation in our grand rounds, bringing in fresh insights and diverse viewpoints that enrich our collective learning experience. Today, it is our privilege to welcome Dr. Bill Young, who was nominated by Dr. Alyssa Thompson, who happened to be an endocrinology fellow and now is our faculty member. For his introduction, I would like to invite Dr. Elias Siraj, our esteemed Division Chief of Endocrinology. Over to you, Dr. Siraj.
Thank you, Sad. So it's my distinct pleasure to introduce to you today our speaker as part of the Dream Speaker Series. And again, thank you, Dr. Thompson, for nominating him. Obviously, not all nominations end up in a selection, but this time it did, and I'm glad it did. So, so Dr. Young, for those of you who may not know him, for a lack of a better word, he's a rock star in endocrinology. I think that kind of sums it up. Dr. Young is a professor of medicine at Mayo Clinic and Tyson Family Endocrinology Clinical Professor as well. Dr. Young grew up in Michigan, and he did his undergrad as well as medical school at Michigan State University. And he did tell me when he was a kid, he came to Virginia Beach, and he remembers that. And that was his first and only Hampton Roads visit until today. And so Michigan State, go Spartans. And actually, I Googled whether Spartans ever played against Monarchs. Some of you might remember, but in basketball, they did, I think, in 2005, and we lost. But in 2007, the women's basketball, we won. Can you believe that? So, so that's that. And then he did his internal medicine and endocrine fellowship at Mayo, and he never left. And Mayo must have treated him very well, and he must be good to Mayo as well. So he grew through the ranks to professor of medicine, and also he was chair of the division of endocrinology. And he became a prominent figure in the endocrine community, in particular in the areas of adrenal disorders, endocrine hypertension, pituitary disorders, and also medical education and medical editing. He also became president of the Endocrine Society at one point. And then also he was the EVMS endocrine board chair, where we overlapped. And actually he was my chair when I was at the EVMS board. He was there when things were good. So if you have complaints about EVMS, it was not him. And then he also did a lot of journal editorialships and leadership as well. He's well published, more than 360 publications. He's a great educator. I mean, if you want to fill up a conference room at Endocrine Society, you invite him as a speaker. And he had more than 750 presentations nationally and internationally. He was invited at least 160 institutions as a guest visiting professor. He has mentored more than 52 international endocrinologists, and on and on. So for the sake of time, I'm gonna stop. And today he will be talking about what the internet needs to know about adrenals. Dr. William, Dr. Young.
Well, thank you, Elias, for that introduction. Can you all hear me okay? Okay. So, you know, what does the internist need to know about the adrenal gland? A couple of my slides from this presentation are shown on this title slide, and you'll learn more about all these in a minute. With regard to potential conflicts of interest, I only have one relationship with industry. It's with Crinetics Pharmaceuticals. on the scientific advisory board. They don't yet have a product that's been approved by the FDA, so there's no conflicts related to this presentation. And I'll not be discussing off-label drug usage. The outline for my presentation is shown here. We'll start by talking about what to do with the patient with low serum cortisol. How do you answer the patient who asks about adrenal fatigue? We'll discuss a protocol to get patients off exogenous glucocorticoids, how and when to test for primary aldosteronism, when and how to test for pheochromocytoma, and then finally, an approach to the incidentally discovered adrenal mass. So low serum cortisol. This is a very common consultation, at least in endocrinology at Mayo Clinic. 99% of the patients with low cortisol at Mayo Clinic do not have adrenal insufficiency. How can that be? Their cortisol is low. Low cortisol is caused by exogenous administration of glucocorticoids, whether it's been injected a month ago, taken orally, inhaled, or applied topically. So the very first thing I do when I see a new patient with low cortisol level is I take a good history. I want to know about exposure to exogenous glucocorticoids and look for signs and symptoms of cortisol deficiency, but also look for signs and symptoms of cortisol excess. This is Thelma. I saw Thelma a few years ago for low cortisol. I walk in the room, I say, she is not missing glucocorticoids. She has too many glucocorticoids, right? She has fatigue, depression, weight gain, proximal muscular weakness. Her cortisol in the blood's undetectable. 24-hour cortisol is undetectable. ACTH is undetectable. DHA sulfate's undetectable. She denies use of oral, inhaled, injected topical glucocorticoids. There's no glucocorticoid on her medication list. I told her that I think she was getting a glucocorticoid from somewhere, and she said, oh, I'd never do that. I would never take steroids. So let's talk about Thelma's vitamins. If you look at, see if I can shine this. So this is the border to Mexico here. Thelma lives in Oklahoma. She'd go across the border. She wouldn't go to the old office. She'd go to the new office down Avenue Madero. And here's the new office where she would get her vitamins. And her vitamins were these orange circular tablets and then these purple triangular tablets. So you can probably guess what we found when we analyzed these in the lab. They both contained exactly the same thing, despite having different colors. They both contain prednisone. So Thelma has exogenous Cushing syndrome due to taking supplements that she was taking for her sore knees, and it's caused iatrogenic Cushing syndrome. So cortisol or any synthetic glucocorticoid feeds back on the hypothalamus to decrease CRH production, decrease ACTH secretion, and the adrenals become atrophic. So, and Thelma's prednisone was doing what cortisol normally would do. So if treatment with exogenous glucocorticoids is documented, you're done. You don't need to do any more tests. But you need to assess whether the patient needs a safety net dose of hydrocortisone while waiting for the hypothalamic pituitary adrenal axis to wake up. It depends how long a patient's been taking exogenous steroids. They've had iatrogenic Cushing's for 6 months. It's probably going to take a year for the hypothalamus and pituitary to wake up. Now, this is not adrenal insufficiency. This is not Addison's disease. This is iatrogenic suppression of the hypothalamic pituitary adrenal axis. But I see this error made in patient charts every day where clinicians write Addison's disease. It's not Addison's disease. This is iatrogenic suppression. And that's my problem title. Addison's disease infers permanent adrenal insufficiency. Now, if you don't find exogenous corticosteroids, well, then I recheck labs. I do 8 AM lab for cortisol, ACTH, DHA, sulfate. If the AM cortisol is normal in a non-hospitalized patient, I'm done. I don't think you need to pursue it further. But if the 8 cortisol is below the lower limit of normal, or in this case, I've used a value that's a bit above the lower limit of normal, well, that might be clinically important. If the ACTH in combination with that lowish cortisol, if the ACTH is high, well, that's primary adrenal insufficiency. DHA sulfate would typically be low in that setting, and we need to figure out why does the patient have primary adrenal insufficiency. Whereas if ACTH and DHA sulfate are low, this is secondary adrenal insufficiency, and we need to determine the cause. But again, it's usually iatrogenic. And one of the best places to look in EPIC is the procedure list, because that's where they're getting injected steroids. How do you answer the patient who asks about adrenal fatigue? Well, here's the book on adrenal fatigue, The 21st Century Stress Syndrome, written by James L. Wilson. And there's Dr. Wilson's picture on the back cover. Now, I didn't buy this book, but this book was given to me by a patient. It was clear to her that I didn't understand adrenal fatigue. So she highlighted some sections for me to read. And here you can see, this is an adrenal gland. He's got an A in his chest here. And this poor adrenal, I mean, he can't win, right? He's getting exposed to coffee, to smoking, to allergies, to toxins, to lack of relaxation. It's amazing this adrenal glands survive. And here's chapter 7, why medicine has not recognized adrenal fatigue. So I have a question for you all. Why would someone write a whole book for patients about a fabricated medical disorder? Why would you do that? Yeah, we got it here. Money. That's why you do it. Well, you don't probably make that much money by selling this book, right? The question is, how do you treat adrenal fatigue? Well, you have to use Dr. Wilson's adrenal fatigue protocol. Now, if you go online tonight, you can get a deal. Instead of $209, you can get it for $188, and you get 3 bottles and 1 vial. It'll fix you for sure. And this is taken every month. Some things never change, right? So back to the question, how do you answer the patient who asks about adrenal fatigue? I tell them, the very last thing in your body that will fatigue are your adrenal glands. They are built for stress. That's what they do. This is a fabricated diagnosis, and adrenal fatigue does not exist, despite what you may have read on the internet. Your symptoms are real. We need to look into what's causing them, but I can reassure you, they're not caused by adrenal fatigue. Okay, getting patients off exogenous glucocorticoids. So you have to remember the 23 rule, 20 milligrams, 3 weeks. What that refers to is a suppressed hypothalamic pituitary adrenal axis is very likely if a patient's taking a glucocorticoid, the equivalent of 20 milligrams of prednisone a day for more than 3 weeks. They're probably going to be suppressed, and you can't cold turkey stop the prednisone. Or if they're taking a bedtime dose of a glucocorticoid, and it doesn't have to be very high, that really does suppress the hypothalamus and pituitary. So if they're taking more than 5 milligrams of prednisone or equivalent per day at bedtime, more than 3 weeks, they very likely have a suppressed axis. Now, the axis suppression is possible if the dosage of prednisone is between 5 and 20 for more than 3 weeks. This depends on individual potency. Some of these patients can cold turkey, no problem. Others get in big trouble. Whereas HPA axis suppression is unlikely, any dose of glucocorticoid for less than 3 weeks. That's the rule. Or if the patient has an alternate day glucocorticoid, they're not going to get in trouble with inability to make glucocorticoid when the steroid is stopped. So we're talking about prednisone. This is the equivalency table. Prednisone right here in the top middle, 5 milligrams. prednisone is equivalent to 0.75 of dexamethasone and 20 milligrams of hydrocortisone. So I'm going to discuss with you a protocol to get patients off exogenous glucocorticoids. Now, you may have a way of doing this you're really happy with. Great. Stick with it. That's fine. If this is something you struggle with, what I'm going to share with you works. The way I view it, the endocrinologist provides the recipe to taper and discontinue glucocorticoids if the treating specialist, which many times is going to be the rheumatologist, pulmonologist, neurologist, deems that glucocorticoids are no longer needed to treat the underlying condition. It's usually because the patient never had the underlying condition. So I'll just give you an example. Let's say the patient's on 20 milligrams of prednisone a day. The first thing we do is we separate the dose to a morning dose and an evening meal dose. So there's 4 times in a day where you can take a drug, morning, noontime, evening mealtime, bedtime. So we drop them to 10 and 5 of hydrocortisone, and we drop the total dosage, prednisone, drop the total dosage by 2.5 milligrams every 2 weeks. So we go to 7.5 and 5, 5 and 5, 5 and 2.5. Once we get them down to 5 and 2.5, then we switch them to a shorter acting glucocorticoid. For the hypothalamus pituitary to wake up, they need a time during the day when they're not seeing exogenous steroids. And that's going to be in the afternoon and nighttime. So that's why we substitute a shorter acting glucocorticoid in the form of hydrocortisone at equivalent dose, 20 milligrams and 10. Then we drop that dose by 5 milligrams every 2 weeks. So 15 and 10, 15 and 5, then 15 in the morning. No more taper. Their axis will wake up on 15 milligrams of hydrocortisone every morning. Once they're on that dose, every 6 weeks, we check a morning cortisol in the morning before they take the morning dose of hydrocortisone. Their last exposure to exogenous steroids was 24 hours ago. We want to see how much cortisol are they making on their own. When the morning cortisol is above 10 micrograms per deciliter, the HPA axis has recovered. Cold turkey, just stop your hydrocortisone and the patient will be fine. We do provide them with stress steroid coverage for 1 year after stopping hydrocortisone. What I mean by that, if they're going for a cholecystectomy, they may need a little help with that surgical stress. You notice I didn't mention anything about cosentropin stim testing in this process. And that's because it's an incredibly overused dynamic test. You don't need to do that. That tells you if your adrenal glands can make cortisol. That's not what I'm worried about. I'm worried about the hypothalamus and the pituitary. Can the hypothalamus make CRH? Can the pituitary make ACTH? Once they're doing their thing, the adrenals are ready to go. So for this to work, it does require patient education. This is the patient education brochure I wrote quite a few years ago. You've been taking a high dose of a cortisone-like medication. Your physician has decided you don't need to take that steroid medication long-term to treat your disorder. This information is provided to help you slowly reduce or taper your high-level dose of the medication. The goal of tapering is to slowly adjust your body to lower levels of cortisone. Tapering is done until you reach the normal range. To help you taper, your physician may prescribe a shorter-acting cortisone-like medication. Examples, prednisone and hydrocortisone. It may take many weeks or months to taper off your steroid medication. Everyone who tapers off a steroid med goes through withdrawal. This includes having flu-like symptoms, muscle aches, and nausea. Going through this stage is a common and necessary side effect of tapering your medication. This is not adrenal insufficiency. This is steroid withdrawal. If you feel so bad, you're curled up in bed, can't go to work or school, your care team will need to slow your taper schedule or change your dose. Everyone has withdrawal symptoms. The goal is to reduce your medication slowly enough that you can handle your symptoms and continue to do your daily activities. Call your care team if you have strong withdrawal symptoms. All patients have withdrawal symptoms. It's up to the patient if they want to go through it. This is something we have to educate the patients about. If they want to take prednisone the rest of their life, that's their decision. We certainly don't advise it. We advise they come off it. So we give them a tapering schedule. We put in the name of the steroid. And for the first 2 weeks, let's say it's 10 and 5 of prednisone. Next 2 weeks, 7.5 and 5, 5 and 5, and then 5 and 2.5. Once they're on that for 2 weeks, we switch them to a shorter acting glucocorticoid, hydrocortisone, at equivalent dose, 20 and 10, 15 and 10, 15 and 5, and then just 15 every morning. And then check a morning cortisol every 6 weeks before they take their morning dose of hydrocortisone. Once the morning cortisol is above 10 micrograms per deciliter, the HPA axis is back online, stop the hydrocortisone. And we have a section about how they get ready for the blood test. We want to make sure they don't take their hydrocortisone before they do their blood test. When I see a high cortisol level, I know the patient didn't follow that instruction because you're not going to get a high level with this protocol. And we tell them when your cortisol is less than normal, then you just repeat this process every 6 weeks. Okay, when and how to test for primary aldosteronism. So primary aldosteronism is the adrenal hypersecretion of aldosterone independent of renin. It's primary aldosterone secretion. So patients have high blood pressure, increased aldo levels, and low renin. All of us in this room, at least most of us, the reason we make aldo is we make renin. When you make more renin, our aldo goes up. If you go on a low sodium diet, your renin is going to be even higher. Your aldo is going to be even higher. If you're on a high sodium diet, you like eating a lot of French fries, pretzels, pizza every day, your renin is going to be low, your aldosterone is going to be low. Patients with primary aldo are making aldosterone independent of what we're taking in salt, and the renin will be low. Their volume expanded. Two most common causes, unilateral aldosterone-producing adenoma. It's what Jerome Kahn described at the University of Michigan in 1955, and bilateral idiopathic hyperaldo. Compared to before 1981, when we thought primary aldo was rare, measuring paired blood levels of aldo and renin as a case detection test, followed by aldosterone suppression for confirmatory testing, has resulted in much higher prevalence estimates for clinically important primary aldo. 5 to 10% of all people with high blood pressure have primary aldo. Think of how many patients you follow with high blood pressure and you've never diagnosed a case. You're missing it. 20% of those with resistant hypertension, 3 drugs, poor control, or any patient on 4 antihypertensive drugs or more, that's resistant hypertension. 1 out of 5 of them have primary aldo. Now, the reason you're missing it is because you're waiting for hypokalemia. But only about 28% of patients with primary aldo have hypokalemia. Most have a normal serum potassium. So, is it a problem if you're missing this diagnosis? Patients with primary aldo have 3 to 4-fold higher rates of MI, stroke, CAD, atrial fib, permanent loss of renal function, and a poor health-related quality of life than matched patients with primary hypertension, matched for blood pressure. So this is not hypertension toxicity. This is aldosterone-specific toxicity. So in view of the high prevalence, it's common. This has been shown in every populated continent in the world. In view of the high prevalence, so much to gain, because you can prevent all those toxicities from happening. We should probably be testing for primary aldo early and a lot. That would make sense. That would make good clinical common sense. So let's see how we're doing. Stanford Health System, a very good health system. 145,000 people with hypertension between 2008 and 2014. They excluded those with CHF, CKD. So they end up with 104,000 individuals with high blood pressure. They look for resistant hypertension. So they had 2,200 on 3 or more drugs, including a diuretic. And then they had 2,400 on 4 or more drugs. That's resistant hypertension. So they had 4,660 patients with resistant hypertension. Now, the endocrine society primary aldosteronism guidelines say they all should be tested for primary aldo because this is a high-risk patient subset. So they all should have been tested for PA. How many were tested at Stanford? 2.1% of this high-risk population was ever tested for primary aldo. Those that were screened tended to be younger, had higher blood pressure readings, lower potassium, and lower rate of treatment with diuretics. So this is a screenshot of the last endocrine society guidelines in 2016. And we identified subsets that should all be screened. That included resistant hypertension, as I'm underlining here. So 100% of the patients in Stanford Health System with resistant hypertension should have been screened for PA. Only 2% were. That's terrible. What about other high-risk subsets? Are we doing any better testing for primary aldo in patients with hypertension, hypokalemia, or hypertension and sleep apnea? These are two other high-risk subsets we identified in those guidelines. Okay, this is a study out of University of Chicago, 116,000 patients with hypertension. They had 36,000 that had hypertension and hypokalemia. How many were screened for PA? 2.7%. Of those with hypertension, sleep apnea, only 3% were screened for PA. So what I'm getting at, the screening rate across the United States, it's not just the University of Chicago or Stanford. It's a sad state of affairs. So 2.1% of resistant hypertensives at Stanford were screened. 2.7% of those with hypertension, hypokalemia were screened. 4.2% at the University of Minnesota of those patients with resistant hypertension were ever screened for PA. And the province of Alberta, Canada, 0.7% of 1.1 million people were ever screened for primary aldo. So here's the deal. Primary aldo is common. Primary aldo causes increased cardiovascular morbidity, decreased quality of life, and CKD, all of which can be prevented with early diagnosis and treatment. But clinicians rarely test for it. So how should we address this countrywide underdiagnosis of primary aldo? This is an algorithm I published back in 2019, when to consider testing for primary aldo. This is a paragraph from that article. Over more than 3 decades, it's been frustrating to see patients who are not tested for PA when they're first diagnosed with hypertension, but rather only after they've developed irreversible stage 4 or 5 CKD. Clinical practice guidelines have not been effective in driving more clinicians to consider case detection testing for PA. I mean, those endocrine society guidelines, it's like we didn't even write them. Could the guidelines be too complicated with regard to rules on medications and by focusing on recommending subsets of patients for primary aldo testing? The algorithm should be simplified. All patients with hypertension should be recommended for case detection testing for PA at least once. So that's what I put in that algorithm in 2019. Again, only 30% of patients with PA are hypokalemic. There is no clinical phenotype. Anyone with high blood pressure is a candidate. It couldn't be more easy. If you can diagnose hypothyroidism, you can diagnose primary aldo. Morning blood test, you measure aldo and renin. That's it. That's all you have to do. And patients can be on any drugs. Don't worry about their blood pressure meds. If the aldosterone is in the normal range, but generous, above 10, and if the renin is inappropriately low, plasma reactivity less than 1, direct renin concentration less than 8, that suggests there's a disconnect. Because remember, we make renin, we make more aldo. Make less renin, make less aldo. These patients aren't making much renin, but their aldo is here. So that's a positive case detection test. Doesn't prove they have primary aldo, but it's a positive case detection test. And then we would go on to confirmatory testing at the next step, but that's something your endocrinology colleagues can do. The primary care internist, if they can start screening for primary aldo, their patients will be incredibly grateful. These are some of the most grateful patients I have. Oh, I'm going to back up and say one more thing. So I wrote this back in 2019 that all patients with hypertension should be tested at least once. But we're rewriting the primary ALDO guidelines right now. They're going to come out in the spring of 2025. And it's evidence-based guidelines. And the very first recommendation in those guidelines is all people with hypertension should be tested for primary aldosteronism. So it's not just me. It's a consensus. When and how to test for pheochromocytoma. So pheochromocytoma is a catecholamiine screen tumor, usually localized to the adrenal gland. Clinicians think about this a lot. We're hardly ever going to find it. But at Mayo Clinic, and I think in every medical institution in the United States, clinicians probably test for this more often than they test for primary aldo. That's backwards. It should be different. This is kind of a sexy diagnosis, right? If you find that rare pheochromocytoma, when you correctly diagnose it, properly treated, it's curable. But if it goes undiagnosed or improperly treated, it can be fatal. This is rare. This is in the hypertensive population, 0.01% to 0.1%. Equally in men and women, primarily 3rd through 5th decades. In 2024, symptoms are present less than 50% of our patients. Most of our patients are totally asymptomatic. And what I'm getting at is the way we diagnose pheochromocytoma has dramatically changed since the first patient in North America was successfully operated in Rochester, Minnesota by Charlie Mayo. So I'm going to show you that very first case in this graphic. We're looking at the percent of patients in 4 cohorts. These 4 cohorts are over time. And we're looking at how they presented. How were they diagnosed? Did they present with paroxysms or hypertension? Was it discovered incidentally? They present with an abdominal mass, or was it found because of family and genetic testing? And you can see the number of patients in each cohort at the bottom of each of these sections. In our most recent publication, 271 patients with pheochromocytoma. So how many present with the classic presentation, paroxysms and hypertension? Well, that's how we used to make this diagnosis, right? I mean, that was over 90% of patients. 84% up to 1980. We started doing body CT scans in the late 70s. It became very common, 95, 2004. So only 51% were detected because of symptoms. In our most recent series, about a quarter. Instead, what's happening now is this says 61% here. 2/3 of our patients are being found by accident before they present with symptoms. They're being found by accident on a cross-sectional computed image done for some other reason. So if you want to find a pheo, look at your CT scans. That's where the money is. 31% were found that way from 95 to 2004. Presenting with an abdominal mass, that just doesn't happen anymore. And being detected because of family testing, genetic testing, that number is increasing. It's up to 12%. Next time we do another cohort, that number will be even higher. So with that background, when should we suspect our patient may have a pheo? Well, if they do present with those classic spells, episodes of forceful palpitations, patients describe it like their chest is a door, somebody's pounding on it. It's a forceful heartbeat. It's rapid, but mostly forceful. Diaphoresis, headache, tremor, pallor. But most patients who present with those symptoms, they don't have a pheo. Resistant hypertension, we should screen them for pheo. If they have a familial syndrome that predisposes to pheo, like MEN2, they need annual biochemical testing. VHL, annual biochemical testing. If there's a family history of pheo, which is about 12% of our patients these days, I screen all first-degree relatives in a new pheo patient. I screen all first-degree relatives who have hypertension. And obviously, we do offer genetic testing for all patients who present with pheochromocytoma. But an incidentally discovered adrenal mass, again, that's where the money's at. 60% of our pheos that go to surgery, it presented as an adrenal incidentaloma. 1 to 2% of all adrenal incidentalomas will prove to be a pheochromocytoma. If they have a pressor response to anesthesia, surgery, angiography, or high-dose corticosteroid, or a beta blocker, yeah, we should think of pheo and we should test them for it. Onset of hypertension at a young age, you can draw that line wherever you like. I use about age 30. So what are the keys to case detection testing? It'd be great if our patients were taking no medications. That never happens, right? The good news is all blood pressure meds are okay. Beta blockers are okay. Alpha blockers are okay. Central alpha 2 agonists are okay. Don't stop any blood pressure med to screen for pheo. The problems with drugs that cause false positive testing are all psychoactivations, tricyclic antidepressants and antipsychotics. That increases CNS catechols. There's an overflow. These are endogenous catechols. You'll find high norepinephrine, high norepinephrine. And Flexeril, which is, at least in the Midwest, commonly used to treat fibromyalgia, actually that is a tricyclic. So if possible, treatment with tricyclics, antipsychotics should be tapered and stopped at least 2 weeks, 4 weeks is best before testing. Obviously, frequently that's not possible. If it's not possible, you can go ahead and test, and if your labs are good, fantastic. If they're abnormal, send the patient to your endocrinology colleagues. It's also important to recognize that catecholamine secretion may be appropriately increased for situations of physical stress and illness, like patients in the hospital. Most patients who are ill in the hospital are going to have high norepinephrine, norepinephrine. It's hard to diagnose a pheo in the hospital. So hypertensive or symptomatic patients, go ahead and get your 24-hour urine for fractionated catecholamines, metanephrines. This is an excellent case detection test. Okay, lastly, an approach to the incidentally discovered adrenal mass. So let's start with the definition. An adrenal incidentaloma is an adrenal mass discovered serendipitously by accident. The reason the CT was performed has nothing to do with the adrenal glands. And in the absence of symptoms or clinical findings suggestive of adrenal disease and of significant size. So we use a cutoff of 1 centimeter. After I discuss adrenal incidentalomas, a common question is, well, what if it's 9 millimeters? What if it's 8 millimeters? I don't care. 1 centimeter is a guide. If it's 9 millimeters, it's clearly a round mass. Yeah, that's an adrenal incidentaloma. The problem is the smaller you make your cutoff, you got to be sure you're not just looking at adrenal limb thickening. That's not what we're talking about here. We're talking about a mass in the adrenal gland. So here's a typical adrenal incidentaloma in the left adrenal gland. And by the end of this section of the presentation, hopefully you'll all be comfortable with what you need to do with this patient. Most of these will prove to be non-functioning cortical adenomas. This is an old study, but the percentages have held up. 3% of all comers will be malignant, 97% benign. Malignant, either primary adrenal cancer or metastatic disease to the adrenals. Benign, about 90% non-functioning. We'll be talking about subclinical Cushing's with respect to the adrenal incidentaloma in a minute, so I'll come back to that. But this is what clinicians are worried about, and this is what our patients are worried about. Do I have cancer? And that's all about imaging phenotype. I can tell which patients have cancer just by looking at the CT. I don't have to talk to the patient, or at least when cancer is highly likely. So I'm going to come back to imaging phenotype in a minute, but I want to review the 3 disorders we need to consider testing for in all patients with incidentally discovered adrenal masses. First is screening for subclinical Cushing's syndrome. This is the subclinical production of cortisol. They don't look Cushingite. So we measure DHEA sulfate. Adrenal DHEA is produced and secreted and regulated by the ACTH. ACTH tells the adrenals to make DHEA. DHEA is made by men and women, different reference ranges change based on age. If you have an adenoma in adrenal making cortisol day and night, that suppresses ACTH, and that'll suppress the adrenal production of DHEA. And you could say, well, why don't you just measure ACTH? ACTH is a volatile hormone, up and down in all of this. DHEA itself has a 25-minute half-life, but DHEA sulfate, 10 to 16-hour half-life, stable throughout the day, no diurnal variation. And it can be used to reflect long-term suppression of ACTH. So this is my adrenal glycosylated hemoglobin. This is a really valuable test when you have a patient with an incidental adrenal mass. If your DHA sulfate is below 40 micrograms, that's consistent with subclinical Cushing's. Now, your endocrine colleague can debate how important subclinical Cushing's is, but if you have a DHA sulfate less than 40 in a patient with an adrenal mass, refer that patient to endocrinology. The other test you could do is an overnight dexamethasone suppression test, DST. You give 1 milligram of dexamethasone at 11 p.m., measure cortisol the next morning at 8 a.m. Normal cortisol the next day is 1.8. But if a patient has an adrenal adenoma constantly producing cortisol, it doesn't care if you gave dexamethasone. It's going to just keep making cortisol. So if it's above 1.8, yeah, that might be this subclinical Cushing's. And we find that in 5 to 8% of all patients with an incidental adrenal mass. And the way I think about it, it's as if the adrenal adenoma is dosing your patient with the equivalent of 1, 2, 3, 4, 5, 6 milligrams of prednisone, distributed evenly over 24 hours, might be the cause of weight gain, hypertension, hyperlipidemia, hyperglycemia, osteoporosis. And I don't think any of us in this room would give a patient 4 milligrams of prednisone for no good reason for the rest of their life. But that's what the adrenal nodule is doing to these patients. And it's important. You don't see any signs or symptoms of this. They don't look Cushing-like. So if you find this with either a low DHA sulfate or an abnormal 1 milligram overnight dex suppression, refer to your colleagues in endocrinology. So when should we screen for pheochromocytoma? You only should screen for pheo if it's a lipid poor mass. So if the unenhanced CT attenuation is greater than 10 Hounsfield units, could that be a pheo? Yes. If it's less than 10 Hounsfield units, could that be a pheo? No. It's impossible. Pheos are not lipid rich. They're lipid poor. So in this instance, you use your imaging phenotype to figure out if you need to test for pheochromocytoma or not. Again, 1 to 2% of all adrenal incidentalomas will prove to be pheo. I think the 24-hour urine is a great test for pheo, but if the pre-contrast CT attenuation is less than 10, don't waste money, don't waste time, don't worry about false positive testing. Don't test for pheo. If the pre-contrast CT attenuation is greater than 10, yeah, might be a pheo you should test. But even then, small pheos, small lipid poor adrenal masses, less than 2 cm, the factory is not big enough to make enough catechols to be detected with our biochemical testing. So all lipid poor adrenal masses should be sent to your colleagues in endocrinology to assess for these issues and could it be a pre-biochemical pheochromocytoma. So lipid poor adrenal masses, go to endo. And last, if the patient's hypertensive or hypokalemic, yes, screen for primary aldo, just the way we talked about before. Measure aldosterone and renin in the morning. The aldosterone's above 10, plasma renin activity less than 1 or DRC less than 8, positive case detection test. And that's the least common hormonal disorder associated with adrenal incidentalomas. So I told you we'd come back to imaging phenotype because this, to be honest, directs 90% of what I do in a patient with an incidental adrenal mass. The unenhanced CT attenuation measured in Hounsfield units. The lower it is, the more lipid, the more likely it is benign. Whereas the higher the density, less lipid, might be adrenal cancer, metastatic disease, pheochromocytoma, lipid poor adenoma, pre-adrenal cancer. So if the pre-contrast radiodensity is less than 10, as it is in this example at -10, can't be cancer, can't be pheo. Could it make aldo? Could it make cortisol? Sure. But it's not a pheo, it's not cancer. I don't worry about this mass in that regard. Whereas if the pre-contrast radiodensity is above 10, as it is in this sample case at 41 Hounsfield units, that's bad news. That's either a small adrenal cancer, a small pheo, a pre-adrenal cancer, wherever it is, it's going to come out. I'll do my biochemical testing. I'll block the patient if it's a pheo, but it's coming out. Lipid poor adrenal masses are bad news. All lipid poor adrenal masses should be sent to your colleagues in endocrinology to address. So to summarize the workup of the adrenal incidentalloma, we think about screening for three things. We get a baseline DHA sulfate and or 1 milligram overnight dex suppression test to screen for subclinical Cushing's. We screen for pheo if it's a lipid poor mass. We do that with 24-hour urine for metanephrines and catecholamines. And we screen for primary aldo if the patient's hypertensive or hypokalemic. If the patient's normotensive, normokalemic, don't screen for primary aldo. If it's a lipid-rich mass, don't screen for pheo. The only thing you have to screen for is that subclinical Cushing syndrome. If any of those labs are abnormal, refer to your colleagues in endocrinology. With regard to imaging phenotype, if it's lipid-rich, non-functioning, we follow them up in 1 year with a cross-sectional image, just to be sure no errors were made the first time around. Whereas if it's lipid poor, like in this case example, and if it's apparently non-functioning, ignore a potentially reassuring radiology report. Don't listen to any radiologist that's telling you what to do with your patient. That's a mistake. You need to know, is this lipid rich? Is this lipid poor? That's all you need to know in terms of risk of malignancy. Because these patients can have pre-biochemical pheos, early adrenal cancer, and they either need surgery or close imaging follow-up. So let me conclude with some take-home points. Low serum cortisol, 99% of these patients do not have adrenal insufficiency. Low cortisol is caused by exogenous glucocorticoids, injected, taken orally, inhaled, applied topically, and sometimes it's taken orally unbeknownst to the patient. Adrenal fatigue does not exist. Symptoms are real. You need to look at what's causing them, but they're not caused by adrenal fatigue. We discussed a protocol to get patients off exogenous glucocorticoids by tapering to a single morning dose of a short-acting glucocorticoid, hydrocortisone, down to 50 milligrams every morning. And then we check a morning cortisol every 6 weeks until it's above 10 micrograms per deciliter. HPA axis is back online. Primary aldo, the most common form of secondary hypertension, 5 to 10% of all people with high blood pressure have this. All people with high blood pressure be tested at least once. Couldn't be easier. Morning blood test, measure aldosterone and renin. Pheochromocytoma is rare. 60% are detected as adrenal incidentalomas. It's all about imaging phenotype and whether it's a lipid poor mass. And finally, the adrenal incidentaloma. Think about subclinical Cushing's with a DHA sulfate level overnight dex. Think about the lipid content. If it's lipid poor, greater than 10 Hounsfield units, screen for pheo. If the patient's either hypertensive or hypokalemic, screen for primary aldo. And imaging phenotype dictates a lot of the management. If it's lipid poor, refer to your colleagues in endocrinology. And I think all patients should have at least one follow-up image. Well, I thank you very much for your attention. Be happy to answer any questions.
Thank you, Dr. Young. One of the unique features of Dr. Young's presentations over the years is how aware he is about his audience. So I have seen his presentation among primary care, and he knows what's important for primary care. I have seen him present to general endocrine audience, and I have seen him present to adrenal super experts. So he does that very well. So I will open the podium for questions. Dr. Osman.
Thank you so much, Dr. Young, for your presentation. I have two questions, if time permits. My first question will go back to glucocorticoid withdrawal syndrome. As seamless as you made it sound, we all know that real life, it's not that easy to take patients off glucocorticoids sometimes. So my question is, when do you suspect, when do you essentially give up and think that the adrenals may be atrophied? Is there any role for CT scan at some point when you're unable to get patients off of steroids?
So the question is there a role for imaging the adrenals if it's taking them a long time to wake up? I mean, you could. I don't think it, let's say you're a year into it and you still have suppressed cortisol. Having said that, the first thing I'd be worried about is if the patient's popping extra hydrocortisone. I mean, because what I showed you works. Does it work in 100% of patients? Nothing in medicine's 100%. Not one thing. You know, you're going to have that one patient in the world that you know, the corticotropes in the pituitary atrophied and died, and they're never going to wake up. Can that happen? I'm sure it can. But yeah, I guess if you're beyond a year and you want to see how atrophic they are, you could image them. But again, for me, that's not where the problem is. The problem's in the hypothalamus and pituitary.
Have you been unable to take patients off glucocorticoids?
One patient. I had the one patient in the world, I think. Yeah. Yeah, one patient. And I said, look, you know, we have lots of patients who are hypopit. We have lots of patients with primary adrenal insufficiency. There's nothing wrong with you being on 10 and 5 of hydrocortisone for the rest of your life.
Can you comment on testing for PRA in people on spironolactone or aldosterone antagonists?
Yeah. So, and I think that's one of the reasons clinicians don't test for primary aldo. They look at the med list, say, oh, patient's on an ACE inhibitor. Oh, they're on a loop diuretic. Oh, they're on an ARB. Oh, no, they're on an MRA, you know, spironolactone or a Pleuronil. Don't worry about drugs. And this is what I put in my up-to-date chapter. Because if your patient truly has primary aldo, it's hard to make renin budge no matter what drug you give them. They can be on every drug known to man that raises renin, and their renin will be low. And 90% of patients with primary aldo who are on spironolactone or Pleuronil on a subtherapeutic dose. Clinicians don't use enough. When they do have a patient with PA, they don't give enough spironolactone or Pleuronil, and renin will be low. And this happens with experts. We just got an article accepted. It's a multi-center international study. One of the targets for treating primary aldo is to make renin go up. That tells you you're blocking the mineralocorticoid receptor. At these centers with experts, the percent where renin was actually in target was really low. It was like 20, 25%. And that was at centers with expertise.
Great talk, Dr. Young. Quick question. How does plasma metanephrines and catecholamines compare to the 24-hour? Your presentation only mentioned 24-hour, and I was under the impression plasma was good enough.
Yeah. So the question is, you know, what's the difference between plasma fractionated metanephrines and 24-hour urine for fractionated metanephrines and catecholamines? The reason I prefer talking about 24-hour urine in this setting is the false positive rate for plasma normetanephrine, not plasma metanephrine, plasma normetanephrine. When you order plasma metanephrine, you get both. You get metanephrine, the major metabolite of epinephrine. You get normetanephrine, the major metabolite of norepinephrine. The false positive rate for plasma normetanephrine is 15%. So we published a paper on this. 97% of patients in Rochester, Minnesota, who are screened for FEO with plasma fractionated metanephrines, 97% have an elevated plasma normetanephrine. I said that a little bit wrong. 97% of those with elevated plasma, normetanephrine do not have a FEO. I mean, what other tests do we have in medicine that 97% of the time it tells you your patient has a tumor and it's wrong? So what happens with plasma mets is it leads to a lot of downstream testing. CT scan, MRI scan, MIBG scan, FDG PET scan, gallium-68 dotatate PET CT. And then they send the patient to me and I say,
That's good for Centera Hospital.
yeah. I mean, it's only minimally elevated. The patient has dramatic symptoms. If you have dramatic symptoms, your labs are going to be dramatic. You know, the patient has a plasma normet of 1.2, upper normal 0.9. That's nothing. We see that all the time. So I think interpreting plasma metanephrines takes a bit more expertise. The false positive rate with 24-hour urine is much lower.
What if we were to use like 3 times upper limit of normal?
Yeah, that'd be okay. But you have to remember that even a blood metanephrine, which is never false positive, even if it's at the high end of normal, that could be clinically important. So when people say, you know, twofold elevated, only listen to that, they're going to miss the adrenergic fields that make epinephrine metanephrine.
You.
Thank you. That was great presentation. Really enjoyed. You know, in hospital, we often have almost, I can't remember any time when I was in hospital and there was not at least one patient with hypertension, 3-4 drugs, poorly controlled blood pressure, those kind of things. And now with your presentation, I'm wondering, is it appropriate, should we be screening these patients while they are in hospital, or that this algorithm should be implemented in outpatient setting and not in hospital?
So assuming the patient's going to follow up in the outpatient setting, my preference would be we screen for FEO in the outpatient setting. The exception is the patient in the ICU who has a systolic of 40, goes to 280, slam back down to 40. That patient's probably got a FEO.
I mean, for the primary
For primary.
Oh, I'm sorry.
Aldo,
Primary
sorry.
Aldo?
Yeah.
I wouldn't screen. There's never a rush to look for primary Aldo in the hospital, assuming you're going to have follow-up. Now, if the patient's a captive audience in the hospital is never going to follow up, sure, I'd test them in the hospital.
Yes, Dr. Young, you mentioned a cutoff of 7 for cortisol when you look for adrenal insufficiency, and then there was another number 10 mentioned later. The difference between those two cutoffs, 7 versus 10, and then also for our primary care audience, and also actually for our endocrine audience, when is a legitimate situation to use ACTH stim test?
Yeah. So the cutoff of 7 microgram per deciliter was in the context of a patient who had a low cortisol previously. If when you recheck it, it is normal, and above 7 is normal, personally, I'm done, unless there's something else that clinical intuition tells you something, you know, the patient actually could have adrenal insufficiency. The cutoff of 10 is to be absolutely certain the HP axis is back online after it's been suppressed. So these are people who have had a suppressed HP axis. I want to make sure they're back online before I stop it. I don't want to get a call from the ER that they come in with adrenal crisis. So that's the difference between those two cutoffs. And then the role for cosentropin stimulation testing, we're going to talk a little bit about that this afternoon in endocrine grand rounds. But I think it's the most overused dynamic test in endocrinology. And in the setting of a suppressed HP axis, it doesn't tell me what I need to know. I want to know, is the hypothalamus ready to go? Is the pituitary ready to go? Once they're ready to go, the adrenals will be ready to go. They'll always be ready to go, except for that one patient. But I think that one patient, it was hypothalamic. So yeah, cosentropin stim testing, I do it to look for congenital adrenal hyperplasia, which is usually not going to come up as an issue in primary care practice. I might use it in a patient with borderline Addison's disease, but most Addison's disease is so simple to diagnose. They're hyperpigmented, their ACTH is 500, their cortisol is low. You don't need a stim test. They're stimulating every minute, every day. I just can't find many reasons to do a co-centropic stem test.
So I think for the sake of time, I think there's another program coming, so we'll have opportunity to ask. Thank you everyone for your attention.